I'm very honored that you're all here joining us for this second webinar we're organizing together with the joint venture of EUSSER, the European Society for Physical Therapists, and SECEC, the shoulder and elbow surgeons. We already had this session done in November, which was a success. So we decided to continue this fruitful collaboration. And we came up with the topic of frozen shoulders. And that's also a little bit because Tim Kraal, the first speaker, he was our previous shoulder and elbow fellow at our institution. And at that time, after hard work, he received his PhD on that topic. So the title of the webinar, Frozen Shoulders, is Supervised Neglect, the best we can do. We borrowed it from Tim because that was the title of his PhD thesis. And that's why I'm very honored that he was willing to start up this webinar with his lecture on the anatomy relating to frozen shoulder. So let's start the first.
And it's an honor to be part of the speakers in this webinar. I've just recently finished my PhD on frozen shoulder, and with this presentation, I'd like to give you some more insight on the pathophysiology. So we'll start off with the diagnosis and the relevant anatomy, which is the easy part, and then we'll move on to the pathophysiology, and that's the more complex cellular processes involved in tissue fibrosis. Just to give you an overview, we think that the pathophysiology is comparable to like a cascade. It starts with a trigger, but often in frozen shoulder we don't know that trigger. But that starts an inflammatory cascade, eventually leading to tissue fibrosis. And there's lots of different cytokines and enzyme systems and signaling pathways involved, but we'll get to that later on. The clinical diagnosis of a frozen shoulder is usually not the problem. There's no clear consensus in the literature, but in clinical practice, we all know that limited passive external rotation is the most characteristic finding in frozen shoulder. Our patient category is often between 40 and 65 years of age, and it's more common in women than in men. But it's good to realize that these patients are in a lot of pain, and often their pattern of sleep is disturbed. And that will cause, in quite a large deal of patients, symptoms of anxiety and depression as well. We've all learned in teach books that a frozen shoulder has 3 different stages: freezing, frozen, and thawing. But for an individual patient, it's quite frustrating that we don't have prognostic factors to predict the natural course of the disease in his or her case. And it's also important to remember that it's not a self-limiting disease for every patient. Like about 1/3 of our patients will have residual symptoms at long term. So let's start at the end. Frozen shoulder is a disease of the glenohumeral joint capsule. The capsule gets thickened and contracted at the end stage of a frozen shoulder. This was already shown in arthrographic studies in the 80s. The capsular compliance gets reduced and the articular volume gets reduced. So there are several clues in the literature that make us think that the process starts anteriorly. Nuclear imaging studies have shown an increased metabolism at the anterior joint capsule. Angiography studies have shown new blood vessel formation at the rotator interval. And histological studies have shown like new nerve growth, neurogenesis, at the anterior joint capsule as well. This is a schematic drawing of the structures involved in the frozen shoulder. I can remove the rotator cuff, and then the articulate capsule in green is exposed with the glenohumeral ligaments. And in blue, you can see the corticohumeral ligament, the CHL. This is found to be an important structure in frozen shoulders. Already back in 1989, it was found that surgical release of the CHL was a successful treatment of frozen shoulders. Nowadays, the CHL thickness can be measured on MRI or ultrasound studies, and this is found to be correlated with the limitations that patients have. At the end stage of a frozen shoulder, you can see that the capsule is thickened and contracted, and that the axillary pouch is decreased. So let's go more into detail. The glenohumeral joint capsule is connective tissue. This contains cells and extracellular matrix proteins. The predominant cell type are fibroblasts, and they can differentiate into myofibroblasts. And the extracellular matrix protein that's most important in frozen shoulder is collagen, and then in an abundant amount in a disorganized fashion. Fibroblasts are quite unique cells. In a normal shoulder, they're latent or dormant, and they're responsible for the extracellular matrix remodeling, synthesis and degradation of collagen proteins. But they can also become activated, and then they've got a role in the recruitment of immune cells, and they can modulate our immune response. Fibroblasts are mechanosensitive cells. They can sense mechanical stress in capsular tissue with their cytoskeleton. And if that mechanical stress passes a certain threshold, they can differentiate into myofibroblasts, which means they can contract using a smooth muscle actin-myosin complex. And this is a self-reinforcing process, because when the tissue gets stiffer, this will increase the mechanical stress that is sensed by the myofibroblasts as well. So schematically, it looks like this. Fibroblasts will multiply, and they will get activated and differentiate into myofibroblasts. Myofibroblasts regulate collagen synthesis through different enzyme systems depicted here. This will result in an abundant amount of collagen type 3 in a disorganized fashion. So there's two factors which will involve this process. That's our inflammatory cascade. And the most important cytokine is transforming growth factor beta 1. And on the other hand, we've got mechanical stress, which will stimulate myofibroblast differentiation. So what's the trigger? How does it start? Is it inactivity or underuse? Because it's often on the non-dominant arm which is affected in people with a desk job and not in manual laborers. Is it minor trauma or even psychological factors which are involved? We're not sure yet, and we often call it an idiopathic frozen shoulder. But what we do know is that there are several conditions predisposing to a frozen shoulder. And there are conditions with a chronic state of low-grade inflammation, like diabetes, cardiovascular disease, and thyroid disorders. You can measure markers of serum markers of chronic inflammation, which are elevated in frozen shoulder patients. What these conditions have in common is that these patients will have an altered immune response, which make them probably more at risk for a frozen shoulder. So this is the same diagram that you've seen before. And now I've added the predisposing factors with a chronic state of low-grade inflammation. And together with the unknown trigger, the alarmins come into play. What are alarmins? Alarmins are signaling molecules which are released on cell stress when cells are in danger or get injured. And they are really the early activators of our immune response. And when measured, alarmins are elevated in the early stage of frozen shoulder patients. The next thing I'd like to explain is the role of hyperglycemia in frozen shoulders. Because we all know that the lifetime prevalence of frozen shoulder is way higher in diabetics than in the normal population. And also, frozen shoulder is more refractory to treatment in diabetics. So how is this caused? It's likely multifactorial, but ages have an important role. So what are ages? Ages are advanced glycation end products, when proteins become glycated after exposure to glucose. And this is formed with covalent bonds. Therefore, ages cannot be degraded and they accumulate in connective tissue during our lifetime. And this happens normally, just in everybody, just with aging. But it's enhanced in people with hyperglycemia. A specific protein of interest is collagen, and ages can form pathological cross-linking between these collagen proteins. This makes the tissue less compliant. So this is where we started, and this will be the last diagram. The fibroblasts will multiply, become activated, and differentiate into myofibroblasts, and they regulate collagen synthesis. They're influenced by mechanical stress and by an inflammatory response. Then we've added the predisposing factors with a chronic state of low-grade inflammation and the role of the alarmins. And lastly, I've explained the role of the advanced glycation end products. In diabetes, the formation of advanced glycation end products is enhanced with pathological cross-linking of collagen fibers. And more, Our ligaments bind to the receptor of age, and ages stimulate the formation of transforming growth factor beta 1. So yes, we've got a better understanding of the pathophysiological processes involved in frozen shoulders, but this is still very much a simplification. But we certainly have some options for medical intervention to stop the cascade to prevent tissue fibrosis. Then one more interesting question. How is frozen shoulder different from arthrofibrosis in knees and elbows? Because the process of tissue fibrosis is actually the same. But in frozen shoulders, it seems to be largely reversible. I don't know, but might it be related to the osseous congruity of the joint? Because a shoulder has a very wide, remarkable range of motion, and the stability depends largely on the capsular tissue compared to knees and elbows. Is it that the fibroblasts in shoulders have a harder job to balance between stiffness and too loose compared to in elbows and knees? So how does this information help us? I think in the future we will move to more specifically targeted medicine to prohibit the inflammatory response leading to tissue fibrosis. This is what we now have. It's our Kenacort. This is our short barrel gunshot to prohibit the inflammatory reaction. And in the near future, we will move on to more specifically targeted medication to block that pathway leading to tissue fibrosis. And TGF-beta1 is an important target. But we do need to avoid the systemic side effects because TGF-beta1 has a very wide role in our body, involved in wound healing, involved in our immune system and cell differentiation. But I believe in the future, we will be able to diagnose a frozen shoulder early and then give specifically targeted medicine to avoid a stiff and frozen shoulder. So my take-home message for today. I know it's a difficult subject because these proteins and these signaling pathways and these cells, that's not something that we deal with in our everyday practice. But I hope I've just given you a little bit more insight in the pathophysiological process of frozen shoulder. So it's a capsular disorder wherein an enhanced inflammatory response precedes a cascade leading to tissue fibrosis. And we've identified certain conditions with a chronic state of low-grade inflammation and an altered immune response that predispose to a frozen shoulder. And both mechanical stress and TGF-beta1 have a crucial and central role in the pathophysiology. And for the future, I think targeted medicine intervening with this TGF-beta1 signaling cascade is a promising therapy. Thank you for your attention.
The bridge from Tim, his talk is to the next speaker. He will talk about injection therapy at early stage in frozen shoulders. And that's being done by Angelo di Giunta. He's a member of the Healthcare and Delivery Committee here with us at the SECEC. And he's, I think he's got a wonderful combination because he's working partly in Sicily, in Italy, in Campania, if I pronounce it well. And he's also partly working on the mainland in Catanzaro. And he's going to educate us about the injection therapy at the early stage of frozen shoulder.
Thank you, everybody. This is Dr. Di Giunta, and it's a really great pleasure being here tonight. My topic is about injection therapy of the early stage of frozen shoulder. We will put on the key points on 6 areas, as you can see in this one, and now little by little we are going to develop once after the other one. Before the colleague talk about the different stage of the frozen shoulder, and I will focus on the freezing area that is a gap period between 10 and 26 weeks, where we are going to have symptoms that include really severe pain of the shoulder, especially at night. What we have to pay attention to evaluate the active range of motion and passive range of motion, especially with, if it's possible, with some scores. And what we got usually is a patient that is let me say, psychologically not exactly strong, and this make really the difference. The patient is the ones that you have on the right side of this view. But another key point is that during the injection therapy, we have to really give the appropriate drugs at the appropriate time, appropriate space where we're going to put on. What we usually inject is a steroid, acid hyaluronic, and PRP, and we have many other things, but we will go to focus on this. The steroids. The role of the steroids is anti-inflammatory and analgesics. What we usually do, in my personal experience, I usually do 3 injections once a week, associated with 10 cc of lidocaine and naropin, which means a big, strong room that we can put in the joint. We have to really be very careful because the effect adverse can be skin burning, skin depigmentation, joint infection. So put everything on a steroid drop on so we can really be safe. The steroids have a short acting, but one of the most used is the triamcinolone acetonide that associated with anesthetics, 1%. This gave immediate pain-free release and can move us on the second steps. But let's say that in these new articles, we can see that the effect of this drug, the steroid, compared with 3 different scores, at the beginning can give a good results, but at the end is the same things. We talk about the SPADI and the score of the constant score and the VAS. Same things happened in this, the corticosteroid, in this review and in this retrospective study, is really the good method to understand that we have to put on just this. But let's compare the acid hyaluronics. The acid hyaluronics gave the benefit of the mechanical support and let me say also anti-inflammatory, but we have to use for the shoulder mainly the middle moderate molecular weight, and that is the most used in clinical practice. Again, 3 injections once a week. What I usually do is put some anesthetics, same needles, then I put the acid hyaluronic and then put again some anesthetics on. This way can give more chance to be fluid, and at the same time the hydrodilation of the joint can be better. We have 2 studies that doesn't give any evidence of superiority of acid hyaluronic compared with the steroids. And we can find this in a systematic review of randomized control trials, and at the same time a randomized control trials too. So it doesn't make any difference. The thing is that we have to focus now on where we are going to put these drugs and how. So I can say that what we see in the literature is much easier for who really do everyday arthroscopic shoulder, and probably the posterior approach is the right one because is the same approach that we usually have for the view of the arthroscopy. Second approach is the anterior approach. Even this can be good because we can have a good right place, safe space between the coracoid and the middle superior portal. The third one is subarachnoid space. Is saved just for the patients that really have less. It's not really a rigidity very strong, which means that I have 120 of elevation and like 80 of abduction. In this case, what we want to release is just the subarachnoid space, and we can put the shot right there. But what we realize with our physiotherapists is this: we make the crunchy patient. We understand that we need an assessment. So we start a dialogue with my physiotherapist, and we look around how we can talk about this. How we can make it. So realize the assessment, and in this assessment, as you can see here, can let me say that we can understand what the physiotherapist feel during the section of his physiotherapy, and what do you really realize with the range of motion, and if he feel something different. At the beginning, as orthopedic surgeon, I did not really realize what means a crunchy score. But crunchy is a sensation that he can feel during the therapy. So, what we did is this. We realized that one, and is really a good language between the orthopedics and the physiotherapy. This is what we do usually since 5 years already now, and it's a really good method. Also, we have all the clinical data on that. But at this point we have to understand which one are the steps. The steps is assisted analgesic action after injection, just a couple of hours, at least 6 hours after the injection, maximum, immediately physiotherapy, and going to with the object to stretch the fibers. We don't want any effect like anesthesia, like many years ago, or like other people do it, because stretch is something. The risk of do it under anesthesia is to tear the tissue, tear the capsula, and destroy the cuff there, and this is a really great damage for the patient. But this is approved also by our colleague, the first one, that says that additional physiotherapy after intraarticular corticosteroid injection is really the main treatment in the early stage. I want to show you that a couple of days ago came in my office these patients that you can see here, and at the same time this is before mobilization, just after my visit, and this is what happened. I make the injection, and after the injection, it's not magic, it's just really we had the crunchy test and the assessment, and this is the physiotherapist was as always impressed, and this is the result that we have just a couple of hours after the physiotherapist. You can see she wear the same shirt, so for sure it's at the same times. It's 3 hours after that. So what I'm saying is that we have to tailor the therapy on each patient and work with a good team of orthopedics, physiatric, and physiotherapists. So my take-home message is we have to make a right diagnosis, accuracy, and recognize the kind of patient at the right time. And then early physiotherapy is associated is effective after injection, and customized therapies with a multidisciplinary team that really make the difference. Now, I thank you a lot for your attention. I send you a good view of my Sicilian island. Thanks a lot. Have a good night.
Angelo, probably a lot of questions after your injection therapy and the treatment you're doing, but we can address those at the Q&A session after this session. Grazie mille.
Grazie, Pep. Thank you.
The next speaker will be Annelies Maenhout from Belgium. She's working as a physical therapist in Ghent, and also partially working at the University Hospital in Ghent, where also Anne Kools and Alexandre van Tongel are coming from. And she will enlighten us on physical therapy at the early stage of frozen shoulder, maybe in combination with injections.
For inviting me tonight to give a presentation on physiotherapy at the early stage of frozen shoulder. I really wished that I could present to you today my biggest kept secret treatment of frozen shoulder in the early phase, a 1-minute simple fix for frozen shoulder, but I'm sorry I have to disappoint you. A colleague suggested on Twitter to go for unsupervised neglect, but I think we can do better than that as a physiotherapist. Okay, let's have a look then at what the reviews are telling us. But also there, I need to disappoint you, because the conclusion is more often substantial evidence gaps, no or insufficient evidence for physiotherapy, for watchful waiting, and so on. But let's not forget what evidence practice is about. This is not only about research evidence, but also about clinical experience and patient preferences. Being both a researcher and a practitioner, I still like to start from the facts to build my practice. And okay, we lack the evidence that we would like to have, the randomized controlled trials, but still there are some interesting studies that give us facts as a starting point for building a therapy program. So the first fact you will probably not ignore, that our patient with frozen shoulder in the early phase is in a lot of pain, experiences sleepless nights, and a lot of uncertainty. From reading this very interesting qualitative study on patient perceptions and priorities when living with a primary frozen shoulder, we can learn a lot and gain insight into how it is to live with a frozen shoulder. They identified patient priorities as regaining function, so regaining mobility might not be their priority. They want to do things again during daily life. They would like an earlier diagnosis, raise awareness and knowledge amongst healthcare staff, and they want a lot of information. So this opens an opportunity for us as a physiotherapist to support our patients with frozen shoulder during the early phase, I guess. So patient education should be an important part of our physiotherapy program in the early phase of rehabilitation and the frozen shoulder patient. In particular, we have to give an answer to the questions of the patient. Like, for example, they wonder what is happening in my shoulder, why is this happening, how long is this going to take, and what are my best options. Now, we don't have a clear answer to all of those questions, but we can provide information to the best of our knowledge and to the best of the knowledge of science and research. The goal of education can be morefold. For example, we can also educate to reduce fear avoidance and make patients aware that they have to try to keep the arm moving within the limits of possibilities. We have to reinforce confidence in the future to increase the good outcome expectations, as we know that this influences pain perception, and we have to motivate them to keep the shoulder but also the full body moving to maintain the patient in a healthy condition. That brings us to our fact number 2. Stiffness is at least partially muscular. This fact is nicely illustrated by the study of Holman, which many of you might have read, on the role of muscle guarding in range of motion loss in patients with frozen shoulder. They investigated 5 patients with frozen shoulder that were planned for arthroscopic release, and they measured their range of motion before and while under full anesthesia. They observed a minimal improvement in abduction range of motion of 55 degrees with even maximal improvement of 110 degrees, and also improvements in external rotation range of motion were seen under anesthesia. The result might not be that spectacular in all patients with a frozen shoulder, and the study population is of course very limited, but at least this study is showing that part of range of motion loss could be explained by muscle guarding, and we should be very aware of that. So how can we reduce that muscle guarding? Well, first of all, muscle guarding occurs in a response to protect the shoulder because it is in pain. And the shoulder in the early phase of frozen shoulder is in pain when we reach near the end or end range of motion. So especially end range, external range of motion, which should not provoke nor in our manual therapy, nor in our exercise therapy. We make the capsule angry if we do that. And the muscles, the antagonists, will try to protect the patient against pain. Instead, we should try to make friends with the enemy. We should make friends with the antagonist muscles. We can use some manual therapy if useful. We can use some muscle release, and especially we can use exercise therapy and learn patients to be aware of that antagonist muscle guarding strategy. That brings us to fact number 4. And fact number 4 is a very important one for us as a physiotherapist, that the harder we work, it is not shown that the more or the better our results will be in a patient with frozen shoulder, especially in the early phase, because we know that painful treatment does not result in superior outcome. And this is a very important fact to base our treatment strategy on. Reviews conclude that there is no indication for manual therapy beyond pain limits. So there is no good argument to provoke pain in our patients with manual therapy, nor with exercises, as it has never been shown that it will result in a better outcome. Instead, there were good results with a treatment program from Dueñas and his colleagues, amongst others Philippe Streff, who investigated a combination of exercise and manual therapy with progression accounting for tissue irritability. So you select your techniques of manual therapy and you select your exercises based on what the patient can bear. So now we have to think, what is not painful in the early stage? What is a window of opportunity? What can we do in our patient? So this brings us to strength training, which offers us a very interesting opportunity in the rehabilitation of frozen shoulder, even in the early phase, and I will show some examples that we can use later. First, I would like to talk about 2 studies. First one is a study of Rawat, who investigated strengthening of the rotator cuff and frozen shoulder, and they had very good results. They showed that adding a structured rotator cuff strengthening program results in improvements in pain, range of motion, and function. But this study was not specifically in the early phase of frozen shoulder, but in general. Second study that I would like to draw your attention to is a review that was recently published on strength training versus stretching to improve mobility. And improving mobility, that is exactly what we want in our patients with frozen shoulder. So this review was not on patients with frozen shoulder, but on a variety of populations. And they compared strength training versus stretching to improve the mobility, and they found that both were equally effective. So that is quite interesting for our patients with a frozen shoulder, because perhaps we don't need to stretch or to use manual therapy or to use mobility exercises, but we can focus on strength, because we know from this review that strength training also is effective to improve mobility. Of course, we don't need heavy loaded strength training in the early phase. We can start with isometric contractions, because we know that moving the shoulder around often provokes the pain. Isometric contractions will be able to be performed by your patient even in the early phase, and not only low load, but your patient will also be able to perform high load contractions if it is mid-range and not end range, near the limitation in range of motion. So some examples: you hold an isometric external rotation. If it's needed for your patient, the hand can be closer to the belly than as presented here, and you can incorporate some lower extremity movement to make the exercise more dynamic. Second one is an isometric abduction to improve the deltoid strength. Your patient will be able to perform that pain-free depending on the range of motion. You can put a chair before your patient, so they don't have to reach full to the floor, but they can reach to the chair, for example. And the last exercise was inspired by a colleague, a physiotherapist that had a frozen shoulder, and she told me that when she provided manual therapy to a patient, that was very helpful for herself to relieve her pain. So in this exercise, we want to increase and decrease alternating the load to the shoulder and having higher and lower muscle contraction around the shoulder. I will show it again. So you lift the hand. This is for the right shoulder. And by going to the foot, you increase the load in the shoulder. By returning to the knees, you decrease the load again. Another window of opportunity in this very painful early phase of frozen shoulder is using the strength of distraction. When in pain, we experience negative pain-related cognitions. For example, we avoid movement because of fear of the pain. But our brain, on the other hand, also has a large inhibition ability of pain. For example, studies in children and chronic pain patients have shown the effect of music and virtual reality on immediate decrease in pain. So at home, what we can do as a physiotherapy is support the patient to find new possibilities, focus on what is possible and not what they cannot do anymore because they are in pain, and support them to engage in meaningful activities. In our exercises, we can also use this distraction, and I will show you what we can do. So we elicit moving the shoulder and using the shoulder without focusing on the shoulder in our exercise. So we focus on a task, for example, maintain your balance or catch the ball. So the patient is not always aware that they are training their shoulder and using their shoulder in a pain-free way because they are focused on something else. For example, this one, you throw the ball towards the wall. Depending on the phase of the rehab, you can step backwards to make it more difficult and to use more elevation. Make sure that your patient does not reach end range of motion, because then you will come near the pain limits and you will see that the muscle reacts to protect the shoulder. Another example, and you can vary as you want. You can make it more challenging for the legs. For example, by jumping. The harder you throw the ball to the floor, the harder it will return and the higher you will push the shoulder into elevation. You can ask the patient to go forward with a tennis ball on one line. Also here, depending on the abilities, you stay within the limits of range of motion. So you stop the patient. Or you can do just balancing exercises on a bossu or medicine ball, because when you want to maintain your balance, you will use or need your arms to maintain your balance. So you are practicing your shoulder without being aware that you are. So this brings me to my takeaway message, as you are already at home. First of all, explain the pain and give an answer to the question of your patients. Second, do not make the capsule angry. Do not provoke the muscle protective mechanism and make friends with the enemy, and use as much pain-free movement as you can. Use gentle mid-range isometric strength training as a window of opportunity, because this will not be painful in your patient if you stay within the limits of range of motion. And fourth, distract the patient, give other tasks, make exercising fun, and incorporate some condition training if you like. Thank you for your attention.
Nice talk with also interesting exercises, which probably we can discuss about. The Q&A session will be chaired by Lionel Neyton. He's also a member of the Healthcare Delivery Committee of the SECEC, and he's from a well-known shoulder surgeon from Lyon, and together with Bruno Santullo, and he's a member of the Educational Committee of the EUSSER, and he's from, I need to pronounce that good, from Asti, where the Spumante, the sparkling wine, is coming from, between Turin and Milan. And they will chair this session. So there's already a few questions in the Q&A session. So gentlemen, please take away.
Thank you, Tjarco, for the invitation to moderate this session.
Thank you, Tjarco. So I think that there are many questions about injections, and especially to Angelo. And one interesting question is, where exactly do you inject the cortisone? So it means that when do you make any difference in a patient to inject for one in the subarachnoid bursa, for one into the articular joint? And you showed us another rotator interval injection. I must admit that I actually don't really understand what it is and makes a difference between intraarticular injection. For me, the rotator interval cannot be really injected inside. So we need some explanations here about the choice between the different locations and what could be the rotator interval injection.
Okay, this is the thing. The idea is analyze exactly the patients because it depends on the rigidity of the shoulder. If I see that it's too stiff in a posterior area, I will introduce posteriorly, very gently. In case if I can see that it's very tight here, especially in minor spectrally, in that case, I will try to give some injection anteriorly between the interval. I'm talking about between the anterior superior portal for arthroscopic surgeon and the anterior medial portal. In that area exactly, if I can see that it's too tight, the capsula anteriorly, I will inject it in that area. So I decide exactly visiting the patients and understand exactly where is it, where starts the rigidity and where is more stiff. This is the first answer. The hydrodilation, I think, helps a lot, and the more I can put in the right place into the joint, the more effect they have. I'll try to answer to some questions writing to the other person, and one of the question is if it's about if the patient after the 3 injection they do something else. Well, the idea is this: they came once a week to me, then they go other 2 times to the physiotherapist, and when we finish the 3 times they continue. That's why we don't have any, let me say, reversibility of the rigidity, because we follow the patient for many, many months.
Okay, thank you. Yeah, thank you, Angelo.
Thank you.
So then we have another question, because after the injection, you mentioned that you want your patient to have right away the physiotherapy exercises. So one question came and asks, what kind of physiotherapy mobilization do you recommend? Because, as it is said, in a way, you always stretch a certain part of the capsule, and I mean that you leave the control of the mobilization to the physiotherapist,
right,
working on the patient. And so what kind of physiotherapy mobilization exercises, and until what limits the physiotherapy can feel where the limit is between I am stretching and I'm going beyond the limit and going beyond the stretch and occurring a tear.
Okay, the thing is because we talk about a lot about this, to share the opinion. I do not understand what they are going to reach with the physiotherapy, because I'm an orthopedic surgeon, so I don't know exactly what they are looking for. But after a long talk for many years, we realized that the assessment, because with the assessment they can really, during the 2 times they go without anesthesia, they go to the limits of the pain, and they stretch a little bit. Let me say 10% more every time. Okay. With the anesthesia, with the anesthesia inside, with the lubricaine inside, they can do a little bit more than usual. So they can reach even 30%. but gently. They don't want to, because they don't want to, let's cry the patients or get to the limits. Otherwise, the patients will not be back next time. So I think and there's a gentle mobilization, elevation first, that's what they, then abduction and external rotation of the hand. And then at the first year, we start to make the mobilization of the scapula. But we understood that the scapula really, if we make the mobilization of the scapula at the beginning, is very, very difficult to reach the range, complete range of motion. So what they say is that they stop the scapula, they leave the scapula like this, they resolve the problem of the scapulothoracic just at the end, and then they focus on just the joint, then glenohumeral joint. That's it. They wanted the assessment because, as I said during the presentation, I do not understand at the beginning the crunchy, what means the irritability. The physiotherapist at the last presentation, she talked about irritability, but as a surgeon, I do not understand at the beginning. So the irritability, I understood that is something that is the maximum they can get to the patient for the pain. And then they start to feel that they stretch just until the hand. I hope I express my answer in the right way.
Okay.
Thank you.
Thank you. I have an interesting question from myself, and I will link it with some attendee question. This is for Annelies and Team Kraal. What do you think about central sensitization in the early phase of frozen shoulder? Do you think this could be possible? And if yes, how can we treat it? And what do you think your thoughts are about mirror therapy and graded motor imagery?
Thanks, Bruno. I will especially comment on the first question and probably leave the second question to Annelies. But central sensitization, I think that's certainly something we have to take in mind in frozen shoulder patients, especially because they've got quite often a long duration of symptoms. And it's also what we find in studies on timing of the intervention that we sometimes do in frozen shoulder patients, like capsular releases or manipulation. You can see in the literature that if the timing of the intervention is after 1 year of symptoms, the outcome is actually worse than before 1 year. And I think that probably has something to do with central sensitization. But it's also a difficult balance, because when you intervene too early, there's over-treatment of unnecessary surgery or procedures. So yeah, that's difficult to balance.
Thank you.
Time to, can you hear me or?
Yes.
It takes some time for the changes in central sensitization to occur. So in the early phase, I don't think that plays a role, but in the later phase, but it depends on the patient. You have different types of people, different types of coping strategies. And I think in patients who have still have a lot of pain, maintain in fear to move their shoulder, they cannot bear somebody touching their shoulder. Those are the signs for the role of central sensitization to me. But that doesn't play a role in all patients, I think.
Okay, so linking with our attendee question, what do you think about mirroring therapy in this case? There's no place for this in the primary frozen shoulder.
We need studies on that to give a clear answer to that. So I'm not aware of a lot of studies. There is one small study in frozen shoulder patients that describe the mirror therapy. Personally, I don't use it a lot. I tried it, but I didn't have a very good experience with it. But in people that have a larger passive range of motion, then that they can use active. So actively, they cannot use all that they have. There I have seen sometimes good results with the mirror therapy. It's like you have to activate the brain again to start using the muscles. So perhaps that could be a place for mirror therapy, but there are different ways to get to the same result, I think, and mirror therapy might be one, but we need more studies.
Thank you very much, Annelies.
Maybe there's room for one more question. I think we could continue at 2100 hours and 4 minutes. So 2 minutes left for another question, maybe.
Lionel, would you like to? If not, I have another question.
Please, please.
I think from a physical therapist perspective, one attendee asked, can too much activity lead to frozen shoulder after rotator cuff repair?
I can probably comment on that. Of course, we know post-operative secondary frozen shoulders. Yeah. And since the fibroblasts are mechanosensitive, you can probably get them angry with overtreatment. But I'm not sure if that's like specific in rotator cuff surgery compared to other kinds of shoulder surgery. But I do think that can be that can be one of the triggers that starts the cascade leading to tissue fibrosis. Yeah.
Thank you.
Well, thank you, Bruno and Lionel, and for all the speakers from this first session. There are still a lot of questions unanswered, maybe in the Q&A session, but maybe we can talk later on those subjects. I would like to continue with the second half of this webinar, and that's, I find, still a very interesting topic, and that's hydrodilation. And luckily we have someone in our organization, and that's Alexandre Ladermann, who from Switzerland. He's in the board of the SECEC, and he published a very nice study on the use of hydrodilation and the results. So please, perfect, thank you.
Yeah, sorry for this. So what about hydrodilation? Biban, you know, I have some conflict of interest, but nothing related to this presentation. What is known about frozen shoulder? I would say nothing, or from time to time liars. If you type frozen shoulder on Ecosia, I love Ecosia, it's better than Google because it just plants trees. And you type frozen shoulder, how long to heal? The first result is coming from Harvard, and it says 2 to 3 years. And in my practice, this is not the case. This is absolutely untrue. I was training with Lionel, Neyton, Gilles Valch, and Lyotard in 2007, and I learned there something very interesting. They were doing stretching very often during the day, balneotherapy, so it was self-stretching, balneotherapy, and 1 injection. And I saw in Lyon miracles. So when I came back to Geneva, I continued to do this protocol. And I wanted to share this knowledge with the whole community, because I think it's very important, because what is written is wrong. And the more I wanted to share, the more I realized that everything was difficult, because we don't even know the name of this disease. We don't know, we don't have a good definition of this disease. We don't know the natural history of this disease. We don't know if there are phases. We don't know how to treat it. And we don't even know when the patient heals. I mean, this is crazy to publish articles in unbelievable journals if in the article you don't know, you are talking about treatment and you say that this treatment is better than other ones, and you don't even know when the patient heals. This is crazy. So I will try to explain you what I did from A to W, because it's not finished. There are ongoing studies. So what is the name of this study? According to me, my definition of this pathology, the natural history, the phases, how we can treat it, and when the patient heals. So what are we talking about? Frozen shoulder has been described by Codman in 1934. And there are alternative names like adhesive capsulitis, fibrotic capsulitis, primary idiopathic stiff shoulder, contracture of the shoulder, blah, blah. We did a review. We performed an electronic review on PubMed with something like 1,600 articles, and we identify and review 6 key through leadership papers published in the last 10 years and 24 systematic reviews that were published in the last 5 years. And the result has been published last year, and you will see that they are quite interesting. For the name, ISACOS and ASCS have published their preference in the term of throat and shoulder. This is mine as well, because we don't find any adhesion in this pathology. However, you need to know that 63% of systematic reviews assessed prefer adhesive capsulitis. For I don't like it, but it's still actually used. What about the definition? So in the ASCS consensus of 2011, they said that throat and shoulder was a condition characterized by its functional restriction of both active and passive range of motion with normal radiograph, okay? They don't talk even about pain. And I think that this is a painful condition. So my definition will be throat and shoulder is a condition characterized by after severe shoulder pain and functional restriction with normal X-ray. Classification, I love the classification of Holmes because for me, this is logical. This is something that I can understand. There are unknown cause. So this is called idiopathic throat and shoulder. And then when the cause is known, if there is risk factors, we talk about primary throat and shoulder, if you have thyroid problems, diabetes, Dupuytren disease, and so on. And then if we are talking about secondary shoulder stiffness, when you talk about secondary shoulder stiffness when you have a trauma sequelae, surgery, immobilization, and so on. So for me, this is very logical, idiopathic, primary, secondary. What about now, what about the natural history? In the 24 systematic reviews that we assess, in 8, it was, in 33% of the case, it was self-limiting. In 30 cases, it was nearly all or self-limiting in nearly all or most cases. And in 25% of the case, it's not self-limiting. And I think this is very interesting. And what about the phases? Usually it's said that there is a freezing, frozen, and thawing phases. In the 24 systematic review assessed, 11 out of the 12 systematic mention and perpetuate these 3-phase model. However, in other systematic review they were talking about 2-phase, 4-phase, phaseless description. And interestingly, we found that there is no science behind it. There is no objective data published to validate either the theory of spontaneous resolution to normal range of motion or progression through phases of pain, stiffness, and then resolution. Zero science behind it. Okay, very interesting. So the description given in the 11 other systematic review, they rely on low quality evidence, or it was secondary sources, meaning that somebody said one day and then you just perpetuate the same definition. So for me, this is a phaseless condition. And now if you want to prove that what has been done in Lyon is the best treatment, you need to compare this best treatment to the gold standard. So this was the next step, and this is what we published in 2021. What is today the gold standard? So we did, it's very complicated. We did a meta-analysis of meta-analysis. So it's an overview of meta-analysis, and it was only randomized controlled trials of very high quality level 1 that compare different types of conservative treatment. And the criteria was so high that the only studies that has this quality were studies dealing with physiotherapy, intraarticular corticosteroid injection, subacromial injection, and hydrodilation with corticosteroid injection. This was the only high-level study. So no acupuncture and so on, because everything was low level. So we didn't even look at this. And the result of our meta-analysis show that distension with corticosteroid provide the best prospect for pain relief in the short term and improvement in range of motion across all time frames in the conservative treatment of shoulders, frozen shoulders. So arthro distension with corticosteroid is probably the best isolated treatment. But I don't want to have an isolated treatment. I want to have a multitude of treatment, because I think that if you do more treatment, you will have better result. So with time, I would like to confirm that the best treatment is a combination of one glenohumeral injection with distension. Completely agree with Lionel and Neyton. The rotator interval is, for me, something that is virtual, impossible to inject in the rotator interval. So it's glenohumeral injection, because this is where is the inflammation. Self-stretching, and I ask my patient to have some pain once per hour from 7 a.m. to 10 p.m. And when you stretch, actually this is something that is painful, but it's only 20 seconds. And this is, you cannot compare this kind of stretching with half an hour of stretching with a physiotherapist. Okay, if you stretch during 20 seconds, 2 or 3 minutes later, the pain vanished, and then you can redo it 1 hour later. And then balneotherapy. So guided injection, there are a lot of questions about it. Of course, it has to be guided. You need to know where you inject. The described thickening of the posterior band of the inferior glenohumeral ligament and the posterior capsule does not exist in my practice. This is never a posterior problem. This is always an anterior problem. Have a look to this nice video. This is an arthroscopic arthrolysis. You have this serpiginous vascularization, and have a look what's happening in the front. So there is a subscap, and I'm trying to find the plane between the subscap and the capsule, the inferior glenohumeral ligament, and have a look. The thickness is almost 1 centimeter. This is where is the problem. It's a very thick capsule, very thick ligament, between 6 to 10 millimeters. And so you continue, stay very close to the labrum. You don't want to detach the labrum, but you don't want to be too lateral, because there is the axillary nerve. So you stay very close to the labrum, and this is posteriorly. Posteriorly, no thickness, 1 or 2 millimeters, it's nothing. So this is not a posterior problem. This is an anterior problem. When this is done, you mobilize your patient, you put the camera again, and have a look. Fantastic distension, and you can even see the axillary nerve. So this is very nice, done under control of the scope. So it was just to show you that this is an anterior problem. It's never a posterior problem. So how do I do distension? You have different type of distension. You can do a capsular rupture versus preservation. For me, the capsular rupture is absolutely a nonsense, because if you break something, it will be by definition either posteriorly, probably posteriorly, exactly where you don't want that something happen. The healthy volume of the capsule is usually between 28 and 35 in a healthy patient. With a patient that has a frozen shoulder, it's between 5 to 10 millimeters. So I just put 8 millimeters of cold water plus the steroid when I do my distension. And this is a very gentle distension. This is more actually to put the corticosteroid. So this is a video. You can do it either with the ultrasound or arthrography on the fluoroscopy guidance in this case. So you just protect your patient, clean everything, inject anteriorly. You make sure that you are at the right place. And when this is done, 8 millimeters, and it's finished. And this is usually a very painless injection. Okay. Sorry. So self-stretching, once per hour, the patient put his hand above the head at the beginning, behind the head at the end. They just stretch like this during 10 seconds, and then they stretch the elbows during 10 seconds. They can do it. They don't need balls. They don't need anything. They can do it at home. They can do it at work, in the bus, in the taxi, everywhere. Very easy. Don't forget that if you ask your patient to do it once per hour, he will do it 5 times per day. If you ask 5 times per day, he will do twice. And if you ask twice, he will do nothing. So that's why I really ask the patient to be regular. And then balneotherapy, they do it in very hot water, 34 degrees. This is in my rehabilitation center. It's very gentle. The hot water is doing everything. So this is one way to stretch. I'm sorry for the volume.
Oh, it's fine. The images are perfect.
Okay, I'm just sorry for the volume. So they do it in hot water. They just stretch gently. They love it. They love it. And this is gentle. Okay. Honestly, 80% of my patients with an idiopathic frozen shoulder are healed or almost healed after 6 weeks of treatment, whatever the phase, if we know that he's healing. 20% of the patient, this is usually long-standing condition. This is patients that are non-compliant. They do inadequate physical therapy with a lot of reinforcement and bodybuilding. It's at the primary or secondary stiffness. This is for them more unpredictable, but it's never 2 to 3 years. It doesn't happen. So what about healing? We don't know. This is an ongoing study. I don't know if the patient is healed when he doesn't have any more pain, when he has complete range of motion, partial range of motion, both. There is no criteria in the literature. This is something that I try to understand. And if the patient has a recalcitrant frozen shoulder, I do not hesitate to do an arthroscopic arthrolysis. If it's a secondary one, I remove the plate at the same time. So this is preoperatively, this is postoperatively. 7 minutes later, this is the result. They have an unbelievable external rotation. This is because you open the rotator interval, everything in the front. They have perfect elevation, but internal rotation hand in the back is still more unpredictable. And this is something that I do not control perfectly yet. So this is preoperatively, postoperatively at 6 weeks. And you see that at 6 weeks, elevation is good, external rotation is very good. But for internal rotation in the back, it's not yet perfect. And it's not the only patient. This is something that I see quite often. I'm quite aggressive in the subcoronal space with the coracohumeral ligament, but this is not always sufficient. Okay. So take-home message, I think that you need to use a comprehensive classification. This is something that is frequent. This wrote on my clinic. However, this is happy patient that will come back with other pathology. This is a clinical diagnosis for me, not a radiological. It's not always self-limiting, and this patient needs treatment. There is no wait and see. It's a nonsense. Distension with corticosteroid is provide the best isolated result. However, it's probably a combination of treatment that works the best. I have 80% of good result at 6 weeks, and I do exceptionally Arthrolysis that can give fantastic results, except for internal recovery. Thank you for your attention, and don't forget the next SECEC Congress.
Alex, for saving us here this way. There probably will be some questions about the amount of fluid you use for the hydrodilation, but we can use that maybe at the Q&A session after this. And in teaching, there's repetition is everything. So the next question will be a bit of overlap for what you already showed, but I think that's not very bad. I'm very happy that he decided to join us. He's George Murrell from Sydney. However, when we came up with the program, we miscalculated a little bit the time difference between here and Sydney at this moment. So that's going to be 3 a.m., 4 a.m. in the middle of the night. So George sent us a great video, but he will not be joining us with a Q&A session. But George is an orthopedic surgeon in Sydney, and he also has a lot of experience with arthroscopic releases, and he will take us step by step in his next talk through this process.
Hi, my name is George Murrell. I'm going to show you today how to do an arthroscopic capsular release in a very efficient and safe manner. I was very fortunate to train with Dr. Russell Warren at the Hospital for Special Surgery in New York. And what he noticed when he scoped patients who'd had a manipulation under anaesthetic for frozen shoulder, that there was a characteristic tear around the shoulder capsule, something like this diagram. So he developed an arthroscopic technique where he would go in and do the same thing arthroscopically. Our first patient today is at a block, a standing block, and I want to show you range of motion. External rotation, maybe about 15 degrees, nice rubbery block. Abduction, 40-50 degrees. For flexion, 70-80 degrees. Internal rotation, wow, I'm just going to even get boundaries behind. It's important to mark out the coracoid process. We always want to be lateral to the coracoid process. We're going to put the scope in a standard posterior port. In a frozen shoulder, it's not unusual for it to be quite hard to get into because the capsule is so thick. A couple of tricks we can use. One is to put a little bit of distraction through the joint once we know we're in the right spot. There we go, and that helps. If you're really struggling, then do the manipulation under anaesthetic first, then put the scope in. But as a general rule, we like to save that anyway for the last part of the case. It's important to rule out a rotator cuff tear and to check on the articular cartilage. Here, the articular cartilage looks nice and healthy, no signs of arthritis. I like to use a spinal needle to establish the anterior portal, and I usually put it just a little bit lower than I would a normal anterior portal. And it's important to look inside the joint to see where it's going to go to give you the best possible position for your portal. The incision can be very small, and here I'm using a 30-degree wand, Arthrocare wand. Here's our superior glenohumeral ligament, in this case quite thick. Next thing we want to do is do a 360 release around the shoulder. I think an important tip is to do the release relatively fast. Don't dawdle, because if you take a long time doing this, the shoulder will certainly get full of fluid, and that makes it quite difficult. The capsule is quite in front of subscapularis, and here I'm dividing subscapularis. I like to divide the intraarticular portion of subscapularis because it's very effective at getting good external rotation, and I've found no detriments from doing this. Here we are continuing to divide the capsule near the glenoid labrum, now down to about 4 o'clock position. Again, it's a very thick capsule down here. The thickness of a normal shoulder capsule is about 2 millimeters and usually quite stretchy. You can see here it's at least 4 millimeters thick, and in some frozen shoulders gets up to 7 millimeters thick. We're continuing to stay next to the glenoid labrum, now down about 5 o'clock, coming into 6 o'clock, and it's quite frequent at this point to get some twitching of the shoulder, and often that's because the heat is irritating the triceps insertion. It's not because you're irritating the axillary nerve. It's relatively straightforward to get down to this 5-6 o'clock position. It sometimes becomes a bit harder around the 7 o'clock position, in which case it's useful to change portals. Before we do that, we just want to make sure that we've got a full thickness division here. a little bit more work to do. But I'm pretty happy so far. Just again, double checking to make sure we've got a full thickness division here. You can see some fibers still remaining around the 4 or 5 o'clock position. So we'll divide those, again, under direct vision. A couple more fibers to get. There we go. We're pretty much full thickness now, down through that 4 o'clock, 5 o'clock position. So now we're going to service the posterior portal, which is just lateral to standard posterior portal and inferior to it. We're pointing our spinal needle towards the scope camera. You can see it coming in here in about that 7, 8 o'clock position of the shoulder. And I'm just burning my way through the shoulder capsule, being very careful, of course, not to damage the articular cartilage. And here we're now down at the 6, 7 o'clock position, using that posterior portal with our wand. And again, the tissue down here is quite thick, quite vascular. We've done a number of studies showing that, lots of little nerves that go with those small blood vessels, and clearly it's those nerves that cause pain that patients note when they reach for something. Now I'm going back up the posterior side of the glenoid at about 8 o'clock here. I'm getting a nice release of the posterior capsule all the way up now to 9 o'clock. And nearly all the way up to 10 o'clock. We've done a number of studies that shows that the more complete the release you do, the more circumferential it is, the better result you're going to get on the table in terms of range of motion, and the better result you're going to get longer term. Now, before we finish, we want to complete that rotator interval release. So we place the wand back up into the anterior portal, and you can see here the fibers just sitting underneath the long head of biceps, which we're going to release. Make sure we get a nice complete release in that superior rotator cuff interval region. Now we're just having a final look around the shoulder, confirm that we've now got a very nice 360-degree release. And you can see our shoulder's a little bit full of fluid, so that's going to make it a little bit difficult. The key with the MUA at the end is to do the major movements first. So I like to do abduction, then forward flexion, then external rotation, and lastly internal rotation. So I did a little bit gently first go. Now I can be a little bit more vigorous. You can see we're going to get 70 degrees of abduction, full flexion. Similarly, on 70 degrees of abduction, we've got 90 degrees of external rotation. And we've got up to T7 internal rotation. So really nice. I do inject corticosteroid in the joint at the end of the operation. Not sure how important that is. More importantly is do not put them in a sling. Do not put them in a sling. Post-op, we like to use cold therapy for pain, though they're not particularly painful post-op. And then the next day they need to initiate an aggressive range of motion program. I can't stress that enough. Physiotherapy, physical therapy is absolutely key to this procedure. You need to keep the shoulder moving after the surgery. When they come back at 1 week, I re-emphasize that they need to use the shoulder as much as possible. There are no restrictions in terms of their range of motion, their lifting capacity, their work capacity. We want them to be very aggressive. What about the outcomes? Well, we looked up a large cohort of patients and followed them for nearly 10 years. Patients reported very severe pain prior to the surgery, which reduced to moderate by 1 week and continued to improve out to mild pain. There was a similar reduction in frequency of pain from daily to weekly by 1 week and then continued to improve to almost no pain at all. There was a significant immediate improvement in range of motions in all directions, like our patient today. And this motion was maintained and was very similar to the contralateral side at the long-term follow-up. Equally important was there were very few complications. There were no recurrences requiring another release. There was no infections, no instability, no axillary nerve damage. We've recently published an even larger series of nearly 200 patients to determine which phase of the frozen shoulder is most helpful to do the capsular release in. As it turned out, all the patients got excellent results, but the very best results were those who were operated on early, who are young, who are female, and had a left shoulder problem. Some final tips. Arthritis of the glenohumeral joint is obviously a contraindication. Patients need to buy into this operation, especially the post-operative rehab. You do an MUA if you can't easily get into the shoulder. Leave the top of the interval to last because this helps prevent too much swollen shoulder. Do the surgery as fast as you can. Again, this helps getting a swollen shoulder. Stay next to the glenoid during the whole procedure. And don't worry if you get a few twitches throughout the procedure. It's usually just the triceps tendon that you're irritating. So to summarize, arthroscopic capsular release gives patients immediate reduction in pain, more range of motion, and in the longer term, these benefits persist with a continued improvement out to the contralateral shoulder and with very minimal or no complications. So I hope this brief video helped you understand arthroscopic capsular release and how to do it effectively and safely. Thank you.
Well, thank you very much with the joint effort from Sydney. And the next speaker is Amar Rangan from the UK. A lot of people know him probably from the PROVER trial, but he's working on a lot of other trials, as I know, because his current fellow is one of our previous residents, and he showed me a picture of all the trials they're doing over there in the UK. I'm very happy and honored that Amar Rangan is going to show us and share us their ideas on the UK Frost trial they did, which was published in the Lancet. So start the video from Amar, please.
Hello everyone. I'd like to thank SECEC and EUSSER for inviting me to contribute to this webinar. I'll be presenting results of UK Frost, which is the largest clinical trial to date comparing hospital-delivered interventions for frozen shoulder. This was a publicly funded trial funded by the National Institute for Health Research in the UK. Those are my disclosures. None of these influenced the conduct or the results of the study. We all know that there are a number of interventions that are commonly used for frozen shoulder of increasing invasiveness. We first had to decide which treatments were important to test as part of a formal trial. So we did two things in preparation for this. Firstly, we surveyed health professionals within the UK, and they identified physiotherapy, manipulation under anesthesia or MUA, and arthroscopic capsular release or ACR as the three main interventions to test in a trial. And alongside this, there was the steroid injection, which was variably used between the three interventions. The problem with the physiotherapy side of it was there was huge variation in how that was being delivered across centers, and so we had to somehow reduce that variation. We conducted the Delphi consensus process to standardize the physiotherapy pathway for the trial, and we called that the early structured physiotherapy or ESP, which included a steroid injection followed by specific modalities of physiotherapy delivered over a 12-session pathway. We also standardized the post-procedural physiotherapy, which followed MUA and capsular release. All this is published within the Physiotherapy Journal. The results of the survey are published in Shoulder and Elbow. Based on that, we designed a three-arm superiority trial where we needed 500 patients, and we compared MUA, ACR, and ESP, or early structured physiotherapy. We conducted clinical and cost effectiveness analyses, a nested qualitative review, and a systematic review. We basically included adult patients with unilateral frozen shoulder, a clinical diagnosis based on greater than 50% restriction in external rotation compared to the contralateral side, and radiographs to exclude other causes of those clinical findings like glenohumeral arthritis or the rare posterior locked dislocation. Exclusions were either a bilateral frozen shoulder to avoid ambiguity in diagnosis, or frozen shoulder secondary to other causes, or if any of the treatments were contraindicated. We also obviously excluded patients who couldn't understand the study procedures or could not be followed up reliably because they did not live within the catchment area of the recruiting center. More importantly, we included patients who had diabetes, and we stratified at randomization to account for that. Our primary outcome was the Oxford Shoulder Score, and the secondary outcomes were as listed here. There were a range of them. We recruited to time and target, and we slightly over-recruited to 503 patients altogether from 35 hospitals across the UK. The characteristics of patients who were recruited were the same as those that were either ineligible or non-consenting, and so we are confident that the study population represents the wider population with the frozen shoulder. The baseline characteristics of the randomized patients were well balanced between the three groups. It's a slightly busy slide, but basically confirms that it was well balanced. The working status had a slight imbalance, and sensitivity analysis confirmed that that did not influence the overall results. Again, another busy slide. What all this says is that the three treatments were delivered to a high degree of fidelity, as was pre-specified in the protocol. So when we look at the analyses, the primary analysis confirms that there was no significant difference that was of clinical importance between the three interventions at the 6-month and the 12-month time points. At 3 months, patients who were randomized to receive the capsular release intervention had significantly worse scores, and that was because a high proportion of these patients had not yet received their treatment at 3 months. So that was because of longer waiting times to access that treatment. So the 3-month differences are basically an artifact of waiting times. But if you look at 6 and 12 months, there was no real difference between the three interventions. And that was the same when we looked at MUA versus ACR, the two surgical interventions, ACR lagging behind at 3 months because they hadn't received the intervention yet, whereas at 6 and 12 months, there was no real difference. Looking at our secondary outcomes gave us confidence that our primary analysis was valid because this pretty much followed the results of the primary analysis. In terms of risk profile, overall the adverse events and the serious adverse events are actually very low across all three groups. But overall the ESP, or the non-surgical pathway, was the safest of the three, and the capsular release pathway had carried higher risks than the other two pathways. Now this was an interesting analysis because if we look at ESP, or the non-surgical pathway, that was the cheapest of the three options and the least risky, but a higher proportion of patients who received the ESP as the primary intervention ended up needing further treatment further down the line. And that had an impact on the overall cost effectiveness analysis when we take ESP as a pathway of care or a philosophy of care compared to ACR and MUA. So when we plot this on a cost effectiveness acceptability curve, the results are quite interesting. So the y-axis shows the probability of an intervention being cost effective, and the x-axis shows the willingness to pay threshold. So within the UK, NICE defines spending up to 20 to 30,000 pounds per quali gain as being acceptable. And so if we take the 20,000 pounds threshold, for example, as willingness to pay, the probability of MUA being cost effective, which is the green line, was 89%. The probability of ESP, or the physiotherapy pathway, being cost effective was about 15%. Probability of the capsular release being cost effective was pretty much zero. These findings are published in the Lancet and are available for you to read. Our observations were, as is listed here, essentially there wasn't a clear winner. None of the treatments were clearly superior, but what we did find was what we would anecdotally find with clinical practice, is that diabetics had worse outcomes irrespective of the type of treatment they received. So when there isn't a clear winner, you need to look at other aspects that might guide the choice of treatment. And so the risks, the risk profile, the costs, and perhaps the waiting times as well for accessing treatment might be important to consider as part of shared decision making between surgeons and patients. In terms of the risk profile and the cost effectiveness, we found that a capsular release as a primary or the first line intervention is perhaps not appropriate. It's probably better to consider the other interventions ahead of that and to use arthroscopic capsular release more selectively. So we have produced a short video, animation video, which actually is available on YouTube freely. So if you type in frozen shoulder trial, you should be able to access it. Many of our clinician colleagues have found it really useful to play to patients as part of a consultation to guide them on what the trial has shown in terms of choosing the type of treatment that they might want to receive. So I'll play that video now just for you to see. It's only about 90 seconds, and I'll end with that.
Frozen shoulder is a common cause of shoulder pain and stiffness. About 8% of men and 10% of women of working age are affected by this disabling condition. They may struggle with basic daily activities. It can also cause sleep disturbance. The exact cause remains unknown. Current treatments aim to relieve the symptoms. For those with persistent symptoms, specialist care in hospital commonly involves a steroid injection with physiotherapy, manipulation of the shoulder under anesthesia, or keyhole surgery. Manipulation and keyhole surgery are also followed by physiotherapy to regain shoulder movements. The UK Frozen Shoulder Trial, UK FROST, compared the effectiveness of the 3 care pathways. It's the largest trial of its kind, involving over 500 patients randomly assigned to one of the 3 groups. All 3 treatments led to significant improvement, but none were clearly clinically superior, using patient-reported questionnaires over a 12-month follow-up. Those who had steroid injection with physiotherapy, the only non-surgical care pathway, were more likely to need further treatment. Keyhole surgery carried higher risks and costs. Manipulation under anesthesia was the most cost-effective treatment to the NHS, providing the best value for money for the benefits gained by patients in terms of their improved quality of life. Thanks to this trial, patients can now discuss the most appropriate treatment option for them with their doctor.
Thank you for listening.
Thank you so much, Amar, for this great overview of the UK FROST trial. The next speaker is Jayanti Ray. She's also coming from the United Kingdom. She works in a town called Ashford, which is in Kent. And she will tell us more about physical therapy after all those treatments, either MUA or arthroscopic release, or hydrodilation, on how you can manage them with physical therapy.
Hi, my name is Jayanti. I'm a physiotherapist. Today I'm going to talk about physiotherapy after the interventions to re-establish the range of motion following manipulation under anesthetic, arthroscopic capsular release, or hydrodilation. Post-operative physiotherapy protocols for all these three procedures are similar. It's important to document the range of movement achieved under anesthetic for future comparisons. Sling is usually not required following these procedures. Physiotherapy must start within 24 hours to ensure that joint is moved in all the direction and planes. Home exercise program should be prescribed to be done every hour. There are no restrictions with regards to range of motion limitations. Patient can return to their activities of daily living as soon as possible and return to work and sports as they are able to. There has been a lot of emphasis in the literature with regards to patient education and advice, and this has been endorsed in recently published Hancher et al. 2020 Postoperative Protocol for UK Frost Tiles. They mentioned that the huge emphasis should be given on educating patients on how to manage their conditions, self-empowering them, and improving the self-efficacy. It's crucial to educate our patient in order to regain the range of motion, as well as to improve the rehabilitation compliance. Simple advice on pain management, education on post-operative rehabilitation protocol milestones, as well as education on lifestyle can help to improve their post-operative rehabilitation journey. In 2020, Hancher et al. Published their UK Frost post-operative protocols, which was meant to be for post-operative arthroscopic capsular release and manipulation under anesthetic patients. I think this is going to have a massive impact on physiotherapy practice, not only for post-operative patients, but in general, how we manage frozen shoulder patients. In their proposed guideline, they mentioned that patients should be rehabilitated in the post-operative phase based on their presentation in the clinic. If a patient presenting in the clinic complains of pain more being predominant than the stiffness, or pain and stiffness equally being a problem, then they are in pain predominant phase, and their rehabilitation should be based on that. If a patient complains of stiffness being their main problem, then their rehabilitation should be based on stiffness predominant phase. These two phases will overlap with each other at varying degree. A patient in the pain predominant phase can present with a stiff shoulder and can have a bit of stiffness. Patient in the stiffness predominant phase can have irritable shoulder and it can be painful. The treatment should be based on individual patient needs. I have taken this information directly from Hancher et al.'s paper, which was published last year. As you can see in the pain predominant phase, as well as in stiffness predominant phase, it's important to give advice and education, as well as home exercise program to our patients. In pain predominant phase, the emphasis is on doing the gentle movement within the pain range, and in the stiffness predominant phase, the emphasis is more on doing function-based exercises, function-based movement, and as the patient progresses, stretching and strengthening exercises can be incorporated. Any other interventions which a physiotherapist feels is important for their patient for their recovery can be incorporated. Passive treatments like electrotherapies, alternative and complementary therapies, and immobilization and brace were discouraged as there was no evidence for them. When we come to rehabilitation following hydrodilation, it's slightly different in terms of aggressiveness. Here, physiotherapy can be started straight away after the procedure, or maybe waiting for 15 minutes to ensure that we monitor the adverse reactions. Jeremy Lewis in 2015 published post-procedure physiotherapy protocol for physiotherapists, and patient education was again emphasized. It was important to move the patient joint immediately after the procedure so that whatever the range of movement has been achieved through the procedure can be maintained or improved. Hence, passive movement was important to be done in the clinic following the procedure. Mobilization and proprioceptive exercises were facilitated, and patients were given home exercise program incorporating active movements, stretching, and self-assistive exercises. So following the procedure, as soon as what we can do is ensuring that patient move their joint in all the planes, including flexion, external rotation, abduction, and internal rotation. Use of cane and stick can be useful to facilitate this movement. Gradually progressing to table slide with the help of a cloth or a ball to ensure that flexion, elevation movements are encouraged. Patients who struggle with the compensatory movement can perform these exercises in supine lying, where they can get feedback and proprioception about the scapulothoracic joint and unlikely to do the compensatory movements. Currently, there are no published guidelines with regards to post-operative management or post-operative physiotherapy protocols for patients after the manipulation under anesthetic, arthroscopic capsular release, or hydrodilation. I have taken this slide from the UK Frost trial, which was used in the trial for all the 3 arms. When it comes to prescribing the exercises for these patients, it's very important to understand the demographic. The patients are usually elderly and unlikely to be doing any complex movements initially when they are in the pain. Keeping the exercises really simple, which they do anytime without need for any assistive device, can be useful and can improve the rehabilitation compliance. Starting with the simple exercises like shoulder shrug, ensuring that they mobilize their cervical and thoracic spine throughout the day by moving their neck in all directions, making sure that whenever they sit in front of computer or driving or doing housework, they're upright or in thoracic extension position, and ensuring that there is some feedback or cues for them to facilitate this movement, including mirror, or probably if you're doing computer work, they can switch on their camera to facilitate this. At an initial painful stage, hand-supported flexion and extension can be performed where patient puts their hand on the thigh and take the arm into flexion and extension with the help of the hand glide. Pendular exercises are useful in early days, especially when they're struggling to move. Gentle swinging arm in the forward as well as sideward direction can help. Adding weight to their hand to provide the traction to the arm can be useful in relieving the pain and improving the circumduction or pendular movement in all the directions. Table slide exercises are a useful way in progressing their movement and improving their elevation or flexion. It can be performed either by moving the hand forward or by keeping the hand sturdy and moving their body backwards. Once they are got a good control of scapulothoracic movement in the gravity-assisted position, it's important to incorporate same movement against the gravity. The simple exercises like wall slide with the help of towel can be useful in achieving the range of movement in the elevation and end range of flexion or abduction. It's very important to ensure that patient has got the scapulothoracic control and there is no compensation. In the stiffness predominant phase, gentle sustained stretches are important to continue and ensuring that's done regularly. Patient can be doing these exercises in any position, ensuring that there is no compensatory movements. Towel or pillow support can be provided where appropriate. Physiotherapy management following manipulation under anesthetic, arthroscopic capsular release, and hydrodistension has never been investigated, and there are currently no accepted guidelines or even evidence-based best practice. Robinson et al. In 2017 concluded in their randomized control trial that there's no difference between patient-led home exercise program, and clinic-based supervised physiotherapy along with the home exercise program in patients who had hydrodilation at 4 weeks' time. Studies have demonstrated that manipulation under anesthetic, arthroscopic capsular release, and hydrodilatations are effective in reducing pain, improving patient functions, and increasing active range of motions. Post-procedure rehabilitation can be based on the pain predominant and stiffness prominent phases. A multimodal approach with advice, education, and exercise prescription are critical to achieve satisfactory post-procedure outcomes, improving self-management and self-efficacy in our patients. Elaine Milmore, in collaboration with the BESS, and Helen Thompson, they both are leading clinical research on frozen shoulder, and hopefully we'll have more in the future to share. Thank you.
Physical therapy point of view on how to treat those patients after all these interventions. Thank you all for staying with us. It's already 10 o'clock, but I think we still have a Q&A session to go, which will be moderated by Ingrid Hultenheim. She's a physical therapist from Sweden, and she's in the Healthcare Delivery Committee of the SECEC, and she will be joined by Alexandre van Tongel, and Alexandre is also coming from the University of Ghent. So please, Alexandre and Ingrid, take away the Q&A session on this second session.
Thank you very much. Is it okay if I start, Alexandre?
Of course, ladies first.
Okay, so a question to Alexandre. What is the working mechanism of hydrodistension or dilatation?
So the way I propose hydrodilation, it's rather relief than distension, a true distension or a rupture of the capsule. I don't like the traumatic rupture of the capsule because, as I said, probably that the lesion is not at the right place. This is rather posterior than anterior, so I don't like it.
So what do you think? What do you mean by relief? Can you explore that expression?
Yep. So there is a very small volume of the capsule. You just create a slight distension. The cold water, and I think that this is an important tip and tricks, is provide an immediate relief, and then corticosteroid injection.
So a relief of the muscle spasm? Is it a way to get away from the muscle spasm, or what is it that is relieved?
It's cold. I mean, you know that cold decreases inflammation. This is a natural phenomena. And this is how I explain the decrease in pain that the patient immediately experiments after the injection.
Okay.
Personally, I have to admit that all the study that we analyzed, because I mean, I published, this is a meta-analysis of meta-analysis. I did none of this study by myself, okay? I just analyzed them. If you analyze the literature, again, nothing is clear. So this is what we found. Arthrodistension seems to be the best method. And I show you my way because the way some people are doing arthrodistension is for me inappropriate, inadequate.
Okay, thank you.
Can I ask another question to all the surgeons who are doing an arthroscopic release, like in the group of Rangan and also Alexandre? Do you perform any biceps tenotomy in this case? Sometimes, never, always?
Never, for me.
And Rangan, was it in your group in the UK Frost when they performed an arthroscopic release?
So the arthroscopic release essentially just involved the core components that we defined were to do a rotator interval release and middle glenohumeral ligament and the anterior capsule, but biceps tenotomy wasn't performed. and also subacromial release. Some surgeons had the preference to do it, but the vast majority don't actually do that in the UK. So I think the biceps, the vast majority of surgeons do not divide the biceps, and that wasn't done as part of the UK Frost trial.
Maybe another thing that I saw, the differences in physiotherapists, and I think also the different healthcare systems in Europe can have an influence on how physiotherapy is used before or after the operation. For example, can every surgeon here in France, in Switzerland, and England, and in the Netherlands tell how many physiotherapy consultations are reimbursed by the government in your country? Maybe first, Rangan?
Yes, so that's a really good question, because I think it is very variable. Even within the UK NHS, it is variable, but generally, I mean, Jayanti, correct me if I'm wrong, but I think most places, in terms of a face-to-face follow-up, would probably do 3 or 4 sessions, with most of the other interval therapy being done as a home exercise program. But the face-to-face consultations are done just to supervise and plan further treatment if required, and to guide further therapy. So the number of sessions that are typically reimbursed are around 3 or 4. For the UK Frost trial, we actually designed a therapy, a particular pathway, which involved up to 12 sessions. Not all of them received 12 sessions. The vast majority received around 6 or 7 and got better and were discharged following that. So up to 12 sessions was allowed as part of the trial. So that was unusual. That's not usual practice, and that's not what is usually commissioned. And so if that particular trial pathway were to be adopted into practice, it would involve further commissioning and further resources to do that.
For example, in Belgium, it's 60 consultations that are reimbursed. How is it in Switzerland?
Until the patient are doing better.
So it can be 10 or it can be 50?
Yeah, sure. Yeah.
And in the Netherlands, Tjarco?
That's a bit depending on what kind of insurance people have. The general rule is that the basic insurance is 12 physical therapy sessions. But if you have a bit better insurance, then it can be, I think, up till 25 or 30, but it's depending on your insurance. But that's for all physical therapy treatment in that year. So if you need physical therapy afterwards for your lung therapy or whatever, and you already use 12 for your frozen shoulder, then you still need to pay them for yourself.
And in your country, Ingrid, how much do you get reimbursed there?
Oh, you know, we are in a socialistic country. It's limitless. So it's up to the physiotherapist to decide. So of course it can be misused, but it also gives a freedom. There is no limit. You should be cautious. It's what we pay for everyone, but it's not nobody else. It's not the surgeon. It's not the state or insurance. It's up to the physiotherapist
and
the patient.
In Italy, I'm working in a private practice, but what I know from my colleagues is that normally they have 1 or 2 cycles of 10 sessions, so maybe 10 or 20 sessions. I think that's it, and then patients get discharged from the public system. And if they need more, of course, they need to get in contact with a private physical therapist.
So may I ask another question? What do you think why do you think internal rotation is most difficult to restore? And should we ask any surgeon here?
So it's always the same. Patient first regain anterior forward flexion, and then external rotation, and finally internal rotation. So when I see my patient at 6 weeks, usually they have full or almost full forward flexion, already a good external rotation, and still a poor internal rotation. And at that time, I introduce the slipper stretch. So this is how it's working in my practice. Why?
May I ask?
Why? I don't know.
And Amar, do you have a comment to this?
I mean, I have no evidence really, but I can give you my view. I think the posterior capsule is a bit more tricky in terms of managing, and as you know, it does contract with other conditions as well. Subacromial impingement, other conditions are associated with posterior capsular tightness. So it's a slightly more complex and perhaps a bit more chronic problem in most of the shoulder conditions, where the posterior capsule becomes more resistant to stretching and treatment. So that's probably why it takes longer to regain internal rotation, I think.
Okay, thank you.
Can I ask a last question to Ray concerning the stretching? Do you propose that people are stretching using activators assisted stretching? I mean, in this position, or do you propose that they try to stretch near to a wall, like in a closed chain stretching situation? Or is there any difference in this kind of stretching protocol?
I think with regards to post-operative patients, we don't have evidence for that. But in tendinopathies, we know that kinetic chain, activating those helps patients to achieve their functional range as well as improve their flexibility of the capsule and strengthening of the muscles.
Well, thank you, everyone. I think, sorry, Alexander, I think we can continue discussing this topic for quite a little longer. However, we said we should finish at 10. In the beginning, we had a bit of technical hiccups, but thanks for all staying with us. And I think afterwards it went pretty smooth. A lot of Q&As still coming in, so there's still room for discussion. And maybe we can do that at other podia, like in Potsdam, where we hopefully can meet in person again, and not all doing this all virtually, because the social aspect is still very important as well, I think. So hopefully we can continue doing this tradition with SECEC user webinars next year with another catchy topic. I'd like to thank all the speakers and faculty members for the Q&A session. And I'd like to wish you all a very nice evening, because we need to go to the Eurovision Song Contest, which is in Rotterdam at this moment. So we need to listen to all the songs. Once again, thank you all, and have a nice evening.
Thank you, everybody.
Thank you, everybody.
Thanks a lot. Bye.
Bye. Have a good evening. Take care.